My name is Adrienne Windsor, and I'm a member of the Newport Beach Public Library Foundation Board. So I get to do this almost every time, and I just love it because this program is so important to us. I always begin also by thanking our generous sponsors, Mike and Polly Smith, and tonight, Mike Smith is with us. So Mike, would you stand up so we can acknowledge you? Mike and Polly have actually backed this program since it was initiated, and they were the initiators of it. At UCI, we had a luncheon meeting, and this thought was cooked up. Wouldn't it be wonderful if we could tap into the resources of this magnificent university in conjunction with our foundation? And Medicine in Our Backyard evolved from that, and it's been going now probably a decade. So this is a huge celebration for us. I also want to acknowledge a couple of other people who don't get acknowledged enough. Kunga Wagmo Upshaw is our program director. Kunga, will you wave so they can see you? And Jane Merritt. Jane is back there at the table. She may have greeted you when you came in. She works with Irvine Health, and the two of them together coordinate this program. So the fact that you're here and doing all of this together has so much to do with the efforts that they put into this behind the scenes. Now, a quick bit about us. The Library Foundation is a membership organization. Our mission is to support the library and fund valuable library resources, services, and stimulating programs. How many of you are members? Well, good. I hope the rest of you become members tonight before you leave. Kunga will be happy to help you with that. One of the advantages is that you get to know about our programs early. Our Witty lecture programs, our library live programs. We have a Witty lecture coming up this Friday, March 3rd, and Saturday afternoon, March 4th, with Dr. Arthur Kaplan. He's a professor and founding head of the medical division of the NYU School of Medicine. He has spoken widely all across the country. He has a depth of knowledge in both medical and biomedical field. And he is described as one of the 10 most influential people in science. So this is an extraordinary opportunity for our community to have him here among us. And then on March 23rd, we have a journalist and author, Omar El-Akkad, who is going to talk about his book, What Strange Paradise. And he shares his experience with the global refugee crisis. The book is based on that refugee crisis. This was rescheduled from last Thursday because he was flying in from Portland, and Portland had a foot of snow, and he couldn't get here. So these are two upcoming things that you might want to put on your calendar and come and join us. I'd also like to mention about the foundation that we undertook the obligation to raise half of the funding for the new Witty Lecture Hall. Our CEO, Jerry Koppel, is in the back of the room. Jerry, would you wave so people can see you? He's headed up that campaign for the foundation, and we're in the last stages of putting all that together. In fact, bids for construction will be coming in tomorrow night. So this is exciting, and soon Medicine in Our Backyard will be in a new lecture hall. All right, so a few reminders. The program concludes with Q&A, so we request you hold all your questions till the end, and then I'll be coming out among you with the microphone so you can ask. And also, if you haven't silenced your phones, please do that right now. And let me say I'm so pleased to introduce tonight's speaker, Dr. Dawn Lombardo. She is such a vivacious, charming woman. It's just been a thrill to meet her tonight. But let me tell you something about her background. She's a board-certified cardiologist who is fellowship trained in heart failure diagnosis and treatment, as well as cardiac transplantation. She is a medical director of UCI Heart Health Failure Program and vice chair of graduate medical education for the Department of Medicine. She is also a professor for the Cardiology Division. She earned her medical degree at Midwestern University of Chicago's College of Osteopathic Medicine. She completed her internship and residency at Evanston Hospital in Internal Medicine and her fellowship at the University of Illinois at Chicago in cardiology. She's also the mother of 3 vivacious young boys and a very, very busy woman. And so please join me in welcoming her tonight, Dr. Lombardo.
Okay. I'm going to stand like this. You can still hear me. All right. First of all, thank you so much. Thank you so much for having me. You can hear me at this distance, okay? Yeah? Okay. Oh yeah, you're going to dim the lights a little bit so you can see that the screen a little bit better. First of all, thank you, Adrian. That was a very nice introduction. I appreciate that, and I really appreciate all you folks coming out in the darn cold. And I'm from Chicago originally, and I've been here a long time now. But I still, see, I wear this in the winter here now. So thank you so much for having me. And I really look forward to speaking to all of you tonight. As I mentioned to Adrian and a couple of the other folks, that it's actually been 4 years since I've done a community or patient-facing lecture. So I got so much I want to talk to you about. My area of expertise is, advanced heart failure, cardiac transplant. But that's not something I want to spend too much time talking about. I'm happy to talk to anybody outside of this because I'm sure everybody here doesn't have heart failure. But what's more important is just cardiovascular disease. All of it leads to heart failure if left untreated, undiagnosed. So what I'd like to talk to you about is kind of heart health. We'll get a little bit into heart failure, but we'll talk about the risk factors and so on and so forth, and things that you can do to try and, help assure the best of your ability that, things stay as good as possible. Does that sound okay with everybody? And you know what? I know Miss Adrian said that no questions during it, but if you want me to continue down one path a little bit more, I'm happy to do so, okay, to make sure everybody gets as much as they can out of the talk today, okay? And of course, I'm always happy to stay afterwards and chat tons, okay? So, is my heart failing? Well, okay, hopefully not, but if it is, we've got a lot of things that we can help to do to give you quality of life and longevity with that quality. But really what we're going to talk about is lifestyle, and what are the aspects of every aspect of your life that you can do to try and help prevent you getting to that point. So I have nothing to disclose. So without further ado, let's do a little brief introduction to cardiac anatomy and physiology, okay? So the heart, it's a special muscle, it's a big fat pumper, okay? And it works within the system. It's a closed fluid-filled system. There's a pump with the whole circulatory system that's attached to it. It relaxes and fills with blood at rest, contracts, and ejects the oxygen, nutrient-rich blood to the head, neck, body, extremities, and all the organs, including the heart itself. All right, the left ventricle, is this the pointer? Yeah, I don't know if you can see that, but this is the left ventricle right here, the right ventricle. So these are the bottom chambers, and there's 2 top chambers. This is your workhorse. So when we talk about heart failure, we're talking about this bottom left chamber. And you can even see that this is thicker muscle than this right side, which is kind of a weak pump, just a conduit basically to bring all the dirty, deoxygenated blood back to the lungs, filter it, oxygenate it, give it to the left heart, and the left heart will bring it all back out to the body and give it everything that it needs from a nutrient standpoint. So the heart is a busy organ. I don't know if you can see this, but I will read it. Automatically, it contracts 60 to 90 times per minute and pumps 1.3 gallons per minute. By age 70, your heart will have beaten at least 2 to 3 billion times and pumped more than 35 million gallons of blood. because it is pumping about 1,900 gallons of blood a day and beating about 100,000 beats per day. So it's a busy little body that's tried and true, most importantly. Okay, so I kind of spoke about it here as a little bit better cartoon of your left heart, your bottom right ventricle as well, and then that's the muscle part, the 4 chambers, the bottom left, bottom right, top left, and then there's 4 valves that direct the flow. Again, oxygen, red, rich blood goes into this main pumper, pumps it out the aorta, that goes everywhere in the body, and then all the blood comes back to the right side, deoxygenated, dirty blood, goes across the valves up to the lungs, and again, oxygenated. So there's your orientation. The cardiovascular system, when we refer to the cardiovascular system, like I said, there's the heart, but the heart doesn't function in a silo. The heart's part of all our parts, right? So there's the cardiovascular system that also includes all our arteries, veins, capillaries, which are micro-sized vessels of the arterial and venous beds, and they comprise the circulatory system. And if you were to actually lay out all the vessels end to end, it would extend for about 60,000 miles, which is enough to circle the earth more than 2 times. So there are a lot of vessels within your body feeding all the organs down to the cellular level. The next part that we talk about when we talk about the heart, so we talked about the muscle, we talked about the vascular system, there's the electrical system. Our entire body runs on electricity, and there's electrical impulses. Some of you have had atrial fibrillation. We'll see a little cartoon later, but basically this guy up here is setting the pace, and there's slick, these yellow lines are an example, not by any stretch of the imagination, the depth and breadth of the electrical pathways that we have embedded within the heart muscle that deliver these fast impulses telling the heart to beat and then relax, beat and relax again, moving the blood throughout the system. So for those of you, when we talk about coronary artery disease, right here, like I said, the heart is an organ just the same, and it's very dependent on oxygen, nutrient-rich blood feeding it just as well. So what is now after that, now we're going to talk about what is cardiovascular disease. So you kind of have a picture of what we're talking about all together, all right? In general terms, the cardiovascular system is composed of the heart, which is that big fat muscle, as well as the valves and the electrical components in the whole circulatory system, all the blood vessels. So when we talk about cardiovascular disease, we talk about, it's a big wastebasket term that encompasses, this is just a smattering of some of the examples like abnormal heart rhythms or arrhythmias, which is just a term for abnormal heart rhythms. Patients who are born with heart disease problems, coronary artery disease, which deals with the blood vessels, heart attacks as a result of blood vessel problems, heart failure, which culminates from any problem that affects the heart whatsoever, and half the time we don't even know what caused the heart muscle to become weak. So there's still a lot to learn, but there's a lot that we have learned, okay? So just to give you a few statistics about how big this is, and well, how big this is. So world's number of deaths by cause, cardiovascular disease. You can't see the number there, but it's this is in the world, 17.8 million. The closest next one is all cancers combined at 9.6 million. So nearly double. Cardiovascular disease is the biggest killer and always has been. All right, and then subsequent to that, there are multiple other diseases. So the scope and impact of cardiovascular disease. In the United States, now not the world, it accounts for about 900,000 deaths. This is 2017 data. Remember, this is massive amounts of data. So these statistics come out from the American Heart Association, depending on what it is, every year up to every 5 years. So that's the amount of deaths in the United States due to cardiovascular disease, and it claims more lives per year than all forms of cancer. You know, again, in the United States, just as I represented in the world. 127 million American adults have some form of cardiovascular disease, and the total healthcare expenditures, $363 billion. That's 2016 data, which is 13% of our total federal healthcare dollars. Just for cardiovascular disease. And actually for heart failure, out of that $360 billion in the cardiovascular disease bucket, heart failure accounts for about 10% of that. So it's the most costly out of the cardiovascular disease processes. When we look at the trends in male versus female, so traditionally, when I started in cardiology, I graduated from medical school in '99, so 21 years. No, it's 23. Okay, I used to be good at math. At that time, when I went into the field of cardiology, it was about 3% female. Now we're up to about 17%. I felt it. It was very notable. But that's okay. I loved what I was doing, and I moved forward through example, I should say. So cardiovascular disease mortality trends. Women, traditionally, all the studies that had been done up until about the last 30 to 40 years predominantly had been all done on men, and predominantly white men. Females, even to this day, represent about 20%. It's starting to get a little bit better. We hit about 20%, kind of stagnated. All of the studies that are done in the world of cardiovascular disease processes, identification, treatment, surgical interventions, devices, so on and so forth, we average about 20% female. But this is a noted effort that came about 20, 40 years, 25, 35 years ago. And since about 2000, so here's the deaths, US males versus female, cardiovascular deaths. So here's female in the red, and then there's male in the blue. This starts at 1990, this is about 2000, and here's 2021. Around 2000, after the efforts were put forth with trying to focus on understanding female pathophysiology a little bit better, underlying disease, so on and so forth, we started to see a notable drop. Now, yes, men dropped just as well, but it was a much more precipitous drop. And the important thing is that we have done an incredible job in the world of cardiovascular disease and improving the mortality of patients. Here's the top 10 causes of death associated for male, female. This is a different way of looking at the data. So men, ischemic heart disease, blockages in the arteries. Females, ischemic heart disease. So about 20%, that is the top cause of death in the United States for all men and women. The next is Alzheimer's disease. That's number 2. And number 3, it swaps a little bit, but stroke, and then lung cancer is right below that. But when you look at the risk factors, dietary risks for cardiovascular disease is the number 1 risk factor. So what type of, how folks are living, it's a broad term, dietary risk. It just doesn't mean, are you eating meat, not eating meat? There's much more that goes into it, but the top 3 are dietary risk, blood pressure, tobacco, and then just under that is overweight, all right? When we talk in terms of risk factors. And when we break it down to how the increased risk is between male and female, hypertension, for example, which is pandemic and is the leading cause for cardiovascular disease processes. Even though blockages in the arteries are a problem, all those risk factors that lead to those blockages, hypertension is number 1 throughout the world, including the United States. And women are at 3 times greater risk as compared to men for developing hypertension, the thickened heart wall. Diabetes, women are 8 times more at risk as compared to men. Coronary artery disease by age 40, lifetime risk is about 1/3 of women and half of men. And men will develop coronary artery disease earlier than women, usually in their 60s, early mid-60s, as compared to women. It'll manifest clinically, usually in your early 70s, and that has to do with timing of menopause. Heart attack, shock. So women tend to have heart disease later in life. They usually have lower bad cholesterol, higher good cholesterol, higher triglycerides. But about a decade, 15 years later, things start to even out. And when we look at non-Hispanic, so black females, actually almost 60% of females have hypertension, and black males, about 60%, have some form of cardiovascular disease. So as a provider, the care team perspective, what's most important to us? Most important is identifying all the risk factors, looking at the patient in front of us, listening to what they're saying, how are they moving, what are they doing, how are they noticing a difference, if any difference, as compared to a month ago, 6 months ago, 12 months ago. and taking all of that information, possibly some testing based on what we're hearing, and trying to figure out if there is something going on that potentially is putting you at increased risk, or there is something going on that's active, or maybe the cat's out of the bag, and taking it a step further, and what can we do about it? So how do we diagnose heart disease? There's a lot of stuff that we do. There's all kinds of tests. There's blood tests. There's non-invasive tests like EKGs. There's treadmills, stress tests, chest x-rays, so on and so forth. And then there's a lot of the advancement in technology as far as imaging is just crazy. It's wonderful, actually, all the non-invasive aspects that we can identify, and being able to look at the number one reason why people develop heart failure is coronary artery disease. It's the most common type of heart disease, and everybody's pretty familiar. Like you can see right here, there's a blockage, and this is a cartoon sampling what the inside of the vessel looks like with the buildup of the fatty deposits, not directly due to fat itself, but the cholesterol deposits that occur. I won't go into that. Okay, so heart attack symptoms, men and women tend to differ. They definitely differ with regards to symptoms that are concerning for blockages in the arteries or something else even going on. When there's heart rhythm issues and the heart rhythm are causing the heart not to function as well, and the patient is having symptoms, and generally, as a general rule, to be very loose, anytime women present with something above their waist, you should take it serious that there's a cardiac aspect to it potentially, versus the typical of shortness of breath or some chest discomfort or something like that. Actually, 90% of women and 87% of women still present with the typical findings. However, women will have additional symptoms like fatigue, don't have the same energy, so on and so forth. I know those are very nondescript, but usually if you try and tease it out, you can come up with, no, this is not normal. Just if I had a nickel for every time I hear from patients, well, I'm aging, I'm 60 now, I'm 70 now, I'm 80 now, so I expect that. And it's like, no, not at all. If there's a difference, we need to try and investigate and find out what's potentially causing that. There should be some reason that is happening. Okay, that should try to be identified. This is actually just an interesting picture right here. So this is all the vasculature feeding the heart. So when people go for an angiogram and we're trying to identify if they're having issues with blockages in the arteries, all we're looking at are these large vessels. And that's the typical presentation for a man. For a female, it's usually problems with all of these small vessels, things that we can't see in an angiogram. And so all these years where they're doing angiograms on women and then the normal vessels look okay, you can kind of see this is nice long tunnel, and then there's a blockage there. This is a typical type of blockage that we'll see in an angiogram. But in women, they have a small vessel disease. So they'll have all these symptoms, but it's not due to the large blockages. So that's something that we're understanding better, especially at the research we're doing in our women's heart program. So coronary artery disease is the number one cause. A lot of risk factors contribute to that. Hypertension is the biggest one. But everything that affects the heart, beyond just traditional risk factors, lifestyle plays a big role. Getting certain types of viral illnesses can cause heart failure or weakened heart muscle. Toxins, some people are more susceptible to too much alcohol, can directly be a toxin to the heart muscle, cause it to weaken. So there's a lot of other things in life, medications that are necessary for cancer treatment. In fact, cancer survivors, I used to do cardio-oncology for several years, and cancer survivors survive their cancer, but ultimately cardiovascular disease, complications, and mortality is what will end up killing them. And a lot of it has to do with the treatments that they've received. It depends on the cancer. It's not every cancer treatment whatsoever, but there's a definite correlation that takes place. So that being said, let's talk just briefly about heart failure here. So the scope of the problem, so you're going to kind of get a feel. Sorry that these are so small. It's not showing very well on this slide. But the total population, so there's about 6.5 million people that are currently walking around with heart failure at this time. It's estimated just by 2030, that's going to be more than 8 million people walking around with heart failure. And it's estimated that between 10 and 20 million people are walking around with undiagnosed heart failure currently because the body is doing such a good job at that time compensating for the failing heart. By age 40, 1 in 5 folks will develop heart failure, contributing to new heart failure diagnoses of about 1 million per year, and half of those folks will die within 5 years if left untreated. All right. There's about 950,000 actually hospital discharges per year for heart failure admissions, and 20% of those patients will be readmitted within 30 days. So 1 in 5 will be right back in the hospital. Because it's portend the fact that you had a heart failure episode. I assimilate heart failure like asthma. If you have asthma, you're not walking around with an asthma exacerbation all the time. You are at risk for an asthma exacerbation, and you have triggers that potentially can put you into an exacerbation. Well, the same thing is with heart failure. No matter what the heart failure type is, it's a weak muscle, it's a stiff, small heart muscle, or chamber, whatever it is, there are certain triggers that can definitely exacerbate it and put you into what we call an exacerbation. And so it's trying to keep control of everything to prevent you from getting hospitalized. A hospitalization portends a worse prognosis and begets more hospitalizations. So we like to try and avoid that, and that's through making sure things that we'll talk about as far as lifestyle, medications, and so on and so forth. There's the cost, like I mentioned earlier. So what is heart failure? The heart isn't pumping blood as well as it should. It keeps pumping to try and meet the needs of the body, but the needs are not being met. And so it creates this continuous cyclical kind of downward spiral. It can be slow and insidious, months, years. People can go 10, 15 years with a very weak heart muscle, but that's been quote unquote on medical therapy and potentially some devices. But, or it can be something that's very quick, like a heart attack. But when we talk about heart failure, it doesn't just mean a weak heart muscle. So here you see on this side that the heart muscle, this chamber is compared to this one. This is that's that main pumper. See how thin-walled it is and how big that chamber is? That's a weak heart muscle. That's where the ejection fraction, that number we talk about as far as kind of correlates to the strength of the pump. That's where they have a very low ejection fraction. This is also heart failure. People who have thickened heart muscle, say from just hypertension that hasn't been adequately controlled over the years. The chamber gets small. When the heart relaxes, it can't adequately receive all the blood that's coming to it. Things start backing up, so on and so forth. And remember, these changes that take place at the heart level, it's the whole cardiovascular system. Everything is functioning together. We're a sum of our parts. Nothing is operating in a silo. So anything that's happening here is either result of something that's going on, but then it contributes to the problem and only exacerbates it. Or something may have initially happened with the heart and set up this whole process. But all of it leads to a continuous downward spiral, but it's not all hopeless. There's a lot that we can do to really have a tremendous impact on patients with heart failure. So, number one is medications. There's a plethora of medications that we can give patients, but there's definitely a cocktail. This GDMT that I have here is called Guideline-Directed Medical Therapy. These are what we call the Fantastic Four. It's a cocktail of medications. I always say, we're going to get you on these medications. My goal is not to just give you a little spit in the wind of the medications. I want to try and get you on the highest doses possible, and I can show you curves that show a direct correlation with how we can improve not only longevity, but quality. All right? The next thing that we can do is, sorry, I changed the slide orders. Okay, so what are the symptoms that we're treating when patients develop heart failure? It can be shortness of breath. It can be shortness of breath just with usual activity, minimal activity, or it can be even shortness of breath at rest. It can be at night when you're sleeping, you suddenly wake up and feel like you need to get some air, like a fan or a window, something to help you, just relieve the sensation that you have of breathing difficulty. You don't necessarily need to be gasping, but it's just you feel like somehow you can't breathe. You can have sometimes a cough at night. You keep waking up with like a dry cough that you don't know where it's coming from. Weight gain. So fluid retention, it just doesn't need to be in the ankles. It can be in the abdomen. It can be just diffuse weight gain. And it can be deceptive because you're actually losing muscle mass under there and you're collecting fluid, for example. Fatigue, more tired than usual, you don't have your usual energy, weakness, and that has to do with muscle changes that are taking place, and then advanced heart failure. There can be confusion and memory issues, which can be reversed if we improve the perfusion. That really has to do with the blood flow issues. Comorbidities in heart failure. Heart failure is a syndrome. Like I said, something is causing it. It's never a priority that you develop heart failure as a diagnosis like, say, diabetes or hypertension. The heart is being bathed in a milieu of badness due to disease processes like hypertension and diabetes, and chronically, that is leading to the heart steadily decreasing in function, or there was an actual problem with the heart itself, say, for example, a heart attack or a toxin such as a particular type of chemotherapy. But most patients have multiple comorbidities when they have heart failure, which makes it very difficult. But you can, the pointer burned out, I think. What this slide is showing here is that the majority of patients have at least 5 other comorbid conditions, hypertension, cholesterol, whatever it may be. So that can lead to difficulties in trying to tease out what's going on with regards to the symptoms that you're experiencing, changes in what you could usually do, so on and so forth, or even from our testing that we do, if we're not seeing as robust a response in stabilizing the cardiac function, so on and so forth. So it can also affect those fabulous 4 that I spoke of, other disease processes. So for example, you have COPD. One of my medicines I like to give is beta blockers, which can exacerbate COPD. Patients with kidney function, another one, 2 of the classes of medicines I like to give potentially can affect the kidneys. So these are things that confound the ability for us to treat patients with heart failure, but we have ways of getting around stuff too. So heart failure, common precipitating factors. We talked about the this is just a smattering of examples: toxins, chemo, recreational drugs, alcohol. So heart rhythm disorders like atrial fibrillation. So narrow valves or leaky valves. It's actually our blood pressure problems. And here we're just showing the fluid collecting in the lungs right there on a chest x-ray. So we talked about the diagnostic tools, the chest x-ray. Here is a normal chest x-ray. You see a lot of the black here. This is a lot of the fluid that collected that's filling up all the air spaces in the lungs. We do EKGs. This is a yucky EKG. This is actually an inferior heart attack that's happening right now. And this one is different. It's maybe you were on a stress test, or you just came in with breathing problems, your heart's going a little bit fast, and it's telling me that the blood vessels aren't serving all of your organs very well. Not necessarily a heart attack, things aren't dying off. This is an echocardiogram. There's that main pumper right there, and if you can kind of get a sense, I don't know if you can see that, you can kind of see this is the chamber right here. You can see this part of the wall's moving, but this part of the wall, you don't see anything moving right there. So depending on the scenario, maybe they're having a heart attack in that distribution right now. This is the bottom right, and then those 2 top chambers. So this is just an example of kind of what an echocardiogram looks like, and then this is an angiogram. And right here is a blockage. This is the main artery that feeds. This system right here feeds about 75%. The right system only feeds about, it varies, but on average 25-30% of the heart. So if you have a problem in the early part of this arterial tree right here, you're going to be affecting a large part of the heart muscle beyond that. So as I mentioned, the problem with heart failure is it's kind of this increasingly continuous downward spiral. So it's really important. Like I mentioned, 10 to 20 million people are estimated in the United States alone to be walking around with heart failure and don't even know it yet. So if I had a nickel for each patient who came in and it was serendipitously discovered on a chest x-ray because they went for a pre-op chest x-ray for, say, a gallbladder. And it's like, oh, your heart looks enlarged, and then the workup ensues. Or they may be having GI complaints, and they went down this long workup for a GI component where actually at the end it ended up being that it was heart failure, and it's just all the abdominal congestion from things backing up due to the problem of heart failure. That being said, it's always kind of yucky to talk to patients about heart failure because there is so much that we can do to try and prevent this. This is over time what ends up happening, quality of life and mortality. So it just keeps going down with these big dips, our heart failure hospitalizations. And this is a very contracted timeline, but, you have this long, nice period, but things continue to increase. So it's very important to try and pay attention. If you're having symptoms, if you're requiring more medications, or you're not capable of taking as much medications as what you normally could for whatever reasons, to try and tease that out and discern whether or not what's going on with regards to the heart muscle itself. It may not be totally obvious on an echocardiogram. There's advanced testing that we do to try and identify subclinical problems, especially like in our chemo patients, all right? And we catch these things in a timely fashion. Again, there's so much that we can do. And this is just an example. Here's that FAB4. No other disease process. We can, a relative risk reduction in mortality of 72% if we can get patients on this cocktail of medications. That is huge. No other disease process can you treat with medications and get this type of response. It's an absolute reduction of 25% in mortality. So a number needed to treat, which is that fancy little acronym right there. 3.9 patients to save a life. It's a lot of life saving that can happen with just getting on the medications. And, I kind of want to emphasize the hypertension thing because I tend to see patients who will come in who are on medications for hypertension, and I just mentioned to Jerry, I think it was, nobody's body reads the book with regards to medications, right? Like, I can take one class of medication and I'm totally fine with it, and then Miss Adrian here may take the same medication and she can't tolerate it till the cows come home, right? So the onus falls on your provider to work with you to find an alternative that you can reap the benefit just the same. Like I said, there's a lot that we can do, even if we have limitations due to intolerance or other disease processes or kidney function, so on and so forth. But the goal is to do everything we can so you can. This is just terrific. And even when we've done this and you're 10, 15 years out, and maybe it gets to a point where, okay, we kind of reached the limit on what medical therapy can do, we have devices and then advanced therapies that we can also do in patients in the right patient population. It's not for everybody. And it's a personal decision. It's not something we just tell you and walk away. This is a very long relationship with a lot of conversations about opportunities potentially if we reach these branch points. Okay? So, in general, with regards to medications, I think it's always important to remember that always having, your medications available to you, the EMRs now and these MyCharts, it really is wonderful with regards to the availability of this and for providers. Me getting information from different hospitals when patients are coming for a consultation, or when my patients maybe admitted someplace else in Oregon or something. It's wonderful, but always knowing the reason that you're taking the medications and trying to understand that. Write them on a piece of paper. This doesn't apply too much as much anymore, but possibly to some. And bring your medications and the original bottles to your doctor's appointments. That one, if you have pictures or something along that line, so incredibly important. So many times patients come in and it's like, well, no, it hasn't changed since last time. Guess what? It almost always has. So bringing those bottles in, it's like, oh, I thought I was taking this. Wow, I didn't realize it was 20. I thought I was taking 10. Or, it just, oh my gosh, things change so much. It's really hard to keep track. And it's no reflection of age. Trust me. It's young, it's middle age, and it's old. It's all across the board. It's the same story. So set a regular routine for taking your medications. Don't let your prescriptions run out. Try and do that, at least a week ahead of time, 2 weeks ahead of time with regards to those refills, making sure that they take place so you don't have a lapse in your treatment, which can cause problems, definitely. People, I forgot if I just mentioned this, some people who have hypertension over the years I've come across, and they're like, well, yeah, I need to give my body a break. I don't want to take all these medications. And so they stop taking their medications like every weekend, for example. That is wreaking havoc on what's going on the inside. And unfortunately, I've seen a couple of strokes happen, one of them my own uncle, as a result of that, giving their body a break. So trying to avoid those, abrupt or missing of doses of medications because of refills and so on and so forth. And then don't stop or change. My chart, send a message. It's not an emergency response system, but, in a timely fashion, there will be a response, or just, give a call. It's so important. And if you miss a dose, don't double up. Just take the next prescribed dose. But if it's something that's incredibly important that you and your provider or your care team have talked about, like if you miss a dose, do A, B, C, D, and you can't remember what it is, give them a call. And, try to do what's in your best interest, for what's going on the inside. As far as the reason I put this slide in here, so we're talking about treatment. So we talked about medications kind of and the impact that they can have. Treatment. So everybody knows what a bypass surgery is and stents are. I want everybody to understand that this is not curing anybody. You still have the disease. All it's done is maybe opened up a few avenues, okay? And many of those avenues, actually, if they're venous bypass grafts, they actually close, a majority of them are closed off within a year. But it's provided other opportunities, so it's not like all, hope is lost whatsoever. But the important thing is that just because you had bypass graft or you had stents and now you're feeling better, okay, which is great, that's incredibly important, you still have disease. And so it's still imperative that you take those medications, number one, which may change after your bypass with time or the stenting, but also lifestyle. The impact, you've kind of been given like a little bit of a reset. So the impact and lifestyle changes can have after that opportunity of bypass surgery or some stents being placed, so on and so forth, are terrific. So with medications. Sorry, I'm a drug pusher. Especially in the world of transplant, we require them. So blockages in the arteries, disease processes to goals, as far as medications, and then we talked about device therapies, or procedures. So some folks I'm sure in here, I actually do know, have had a history of AFib and had ablations, and what AFib is, instead of that guy up there being the soldier setting the pace for the heart. Both of these chambers at the top, you see all these guys up here, they all want to try and take over and be the lead soldier setting the pace for the heart. And so then the heart just starts going blah, 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 instead of doing these nice synchronized contractions. And all this jelly movement is actually what puts people at increased risk, because blood is allowed to sit a little bit. When blood sits, when you bleed, you get that little clot. And then all of a sudden you get a nice organized contraction and that clot can go off. It can be potentially non-clinically significant. You didn't even know that it happened, or, to the point where it's, irreversible and end up in a home with caregivers, which is poor quality of life, or of course even death. So ablations, if the heart's going too fast, and I talked a little bit about the importance of getting that treated, or pacemakers. Again, heart rhythms can lead to heart failure, whether it's too fast or too slow. So getting that identified and treated. Defibrillators, and then the fancy pacemaker that goes with the defibrillator, the cardiac resynchronization therapy, that adds an extra lead over on the left side, and what it tries to do then is coordinate the contraction of both the left and right side of the top and bottom chambers. So that coordinated motion, or that coordinated or synchronized contraction, can potentially help to make heart muscles stronger again. If the reason is a disorganized contraction. So heart problems, replacing leaky valves, opening up narrow valves. So all in all, what I'm trying to get across is it's a spectrum. It starts at one point, and it's best to try and identify early on what stage, we classify in stage just like cancer, A, B, C, D. It's irreversible. You start at the beginning in stage A, you're high risk, you have disease processes, i.e. hypertension, something like that. You're at risk. 80% of hypertensive diabetics develop heart failure. So it's huge. So treating disease processes appropriately, recognizing them, trying to, according to national guidelines, so on and so forth, is very important to try and prevent getting to stage B, which means that not necessarily you have heart failure yet, you've got some structural heart problem as a result of things maybe not being treated as well, haven't been identified, so on and so forth. All the things, that come into play. And then moving on to stage C is where now you've had a heart failure episode. And once you've had a heart failure episode, you are always stage C, and your risk of mortality definitely increases as you progress to here. And then the stage D population is the population that I talked about, where we have devices, advanced therapies like VADs and transplant. So when you reach advanced heart failure, I keep pressing the 4 button, I'm sorry. There's ventricular assist devices, and this is actually a pump that we put in lieu of doing a transplant. And then there's also, depending on patients' goals of care and everything else that comes into play, it's a whole team of folks working with patients and their families. And if this is the best thing, the best outcome that's in line with the patient's goals of care and medical condition, this is the third option that is provided to these patients. And the reason that the VAD actually, when I started in transplant, I actually started as a medical student transplant, but even when I was in general cardiology fellowship, these pumps were like a big box that was in the corner of a patient's room with massive tubes coming out of their chest, and they would be there 2 months, 3 months, 6 months, so on and so forth, waiting for a heart. And these pumps have evolved into this now, and patients live with this. We implant these pumps, and a patient can go home 2 to 4 weeks, barring issues, because there are always issues, just hopefully they're not big issues. Go home and live their life with this, except they don't take baths or swim in a pool. So this is for patients who don't qualify for a transplant, or perhaps they're too sick right now to get a transplant, and we can get them to a transplant with this left ventricular assist device, which is a pump. And the reason that those have evolved and become what we call durable ambulatory LVADs is because transplant, the numbers haven't changed. This bar is basically telling you that there's about 3,000 hearts that become available a year, and it hasn't changed. And there's about less than 10% of the patients who have heart failure that get a transplant, and the rest are left to die. So this is a wonderful option in patients. We implant even up to about 80 years old, depending on, again, everything. It's not just, oh, you have a weak heart, we can put a VAD in, or you have a weak heart, we can transplant you. It's way bigger than that, but it's working with the family. I always say we become attached at a cord, and everybody gets in everybody's business to make sure that this is the best option that's going to provide quality with the quantity, because it's definitely going to give quantity, but we want that quality with it, and what are the goals of the patient. So just a little cartoon right down there for the VAD. It's not playing, but there's a pump, and it's coming. It should show how it sucks the blood out right here, and then it delivers it to the aorta instead of the heart just pumping it itself. There's still some native heart function, but it's not enough to support life, and that's what the VAD does. So what can you do? So preventative cardiology, an ounce of prevention worth a pound of cure. No, it's not a pound. It is tons of cure. Lifestyle, if I just could write a prescription for lifestyle, and whatever the patient wants to know, I will write a prescription for. The impact that lifestyle has is massive. Just massive. And massive is, lifestyle is a big, big bucket though. We're talking about activity. I don't use the word exercise, even though I'm an athlete. I don't use the word exercise because it scares a lot of people. It's like moving. What are you doing on a daily basis to be active? What are you doing to challenge yourself also on a daily basis from an activity standpoint, or at least, 5 days a week? What kind, I always work in baby steps, the low-hanging fruit per se, with regards to diet. And I talk about like everything. This is, obviously, none of this takes place in one meeting or 2 meetings or 3 meetings. There's a whole team of folks that I work with. This is ongoing. From the time that we meet, as far as education, there is so much. I've been in this for over 20, however many years it was, 24? 24 years, and it's information overload for me even to keep up, all right? But it's so important for me and the folks, the team that, we have together to be able to educate, and that's our role with regards to try and provide patients the opportunity. So knowing your numbers, knowing your risk, lifestyle changes, trying to educate you step by step. TMI is never good. A lot gets lost. But so the bad news is, I already brought it up. Even though you had a procedure, doesn't mean that you're fixed, right? You still have the disease. So we still got to work on lifestyle, okay? That big basket of lifestyle. So the good news is you can do a lot to decrease your chances significantly. And then even if the cat's out of the bag, protract that course to poor quality of life or even mortality. Okay, so there's a lot that can be done. So talking with your provider. So knowing your numbers, these are all important numbers. So blood pressures, we generally want 120/80. When you get to 130/80, we're already calling that pre-hypertension. Way different than 20 years ago, okay, where it was at 140/90, okay? 120/80. Total cholesterol, as a general rule, less than 100. The bad cholesterol, the LDL, L for lower. Bad cholesterol, L for lower, we want it. Less than 100, but that depends on other disease processes a patient may have. The good cholesterol, H, higher. HDL is the good cholesterol. H for higher, the better. 60 is really tough. 40 to 60, okay, I'm really happy. I don't care if you go from 34 to 37, I'm thrilled. It's really hard, but the benefit to be reaped from it is wonderful. Triglycerides, waist circumference, that's something we call metabolic syndrome. Waist circumference plays a big role in risk for cardiovascular disease processes, whether it's coronary artery disease, heart failure, stroke, so on and so forth. BMI less than 25, Asian population less than 23. That's your weight over kilograms over meters squared. So BMI over 30 has a significantly increased risk of heart disease. 30 is considered obese, 35 is morbidly obese, 25 is overweight. This is an inflammatory marker. This is how your sugars are doing. Even so, less than 5.6, it's about actually 7%, depending on the patient and disease processes. But even when your sugars are controlled, A1C less than 7%, it still puts you on average at a 4% increased risk of developing heart failure. So there's a lot that we still need to learn. So non-modifiable risk factors, the really important thing that I just wanted to point out here is there's a lot of modifiable risk factors. These are the typical ones that you always hear about, but atrial fibrillation, all of these risk factors, uncontrolled, increases your risk of atrial fibrillation, let alone age alone. Age is a risk factor for atrial fibrillation. By age 80, 25% of the population will have atrial fibrillation. It will expedite the risk of developing atrial fibrillation the more risk factors you have, and even if it's not that many risk factors, uncontrolled risk factors. So this is something in the last handful of years that we've identified a strong correlation with the traditional risk factors increasing the risk of atrial fibrillation. And nobody wants to have a stroke. This is very busy, and all I'm going to point out is blue means that these are the risk factors. Smoking, weight, physical activity, healthy diet, cholesterol, blood pressure, and diabetes, I think, is at the bottom. Blue means it's controlled. Red means it's okay. Yellow means not controlled at all. That top one is smoking. So in the breakdown, the 4 lines are white, black, Asian, and Mexican American. Everybody's doing pretty good. They're well controlled as far as tobacco. We've done a great job. No, You Come a Long Way, Baby was not. That was airlines, wasn't it? I'm trying to think of one I can't. So body mass index. So red is, my thing's not working. Red is mediocre right there. So the second 4 bars, everybody's mediocre with regards to their weight. Physical activity, they're either red, that's the... Can you hear me if I talk like this? I don't think I know. Yeah, okay. All right, sorry. My pointer's not working. This one is a healthy diet. Everybody's in yellow, right there. This is physical activity. If you're not in red, you're bordering yellow or you're yellow. So doing a bad job. Physical activity, doing a bad job. Weight, cholesterol, okay. This is blood pressure. Biggest thing contributing to heart disease is risk factor is blood pressure. So I just thought that was a nice little visual to put things into perspective. And then here, the Life Simple 7, obviously controlling your risk factors. The American Heart Association, AHA.org, has wonderful patient-facing information with regards to all of this. You can dive down real deep in any one particular area or all the areas, trying to touch all of them about what you can do overall from a healthy lifestyle perspective. But Life Simple 7 is what they're calling this now. So get active, and so just some funny things. My favorite exercise is a cross between a lunge and a crunch, so I call it lunge. Or I did a push-up today. Well, actually I fell down, but I used my arms to get back up, close enough, so I need some chocolate now. So 70% of Americans do not get the physical activity they need. Physical activity increases not only quantity, but the quality of life also. The data that's come out in the last couple of years, and just in the last 6, 8, 10 months, something like that, huge exercise study, the risk for cardiovascular disease is significantly decreased with moving. So regular exercise can decrease your risk of cardiovascular disease by half easily. That's more. So these, I'm going to fly kind of through these. Usually I leave these slides in. I can go to them if you have questions about it, but eat a lot. What I tell my patients with regards to food, this is the simple rule. Colors. Every color of the rainbow, every day, several times a day. All right? So a lot of those dark leafy greens. Okay, if you're on Coumadin, talk to your doctor. All right? You don't go on a salad binge and stuff like that. But outside of that, every color of the rainbow. Red meat, 0 redeeming factors. I know a lot of people enjoy it, then make it a treat. All right? And I don't mean a treat. You don't get treats 7 days a week, and you don't get it 5 days a week, but maybe once a week, once every couple of weeks, so on and so forth. Go out, go for the gusto and get that favorite meal, whatever it is that you might have. But other than that, paying attention to lean meats definitely reaps benefit from a cardiovascular standpoint. This is just another fun visual, obesity rates. You can't see it, but there's a line up here. That's the United States. So this is the world, all right? Down here is even Korea. Everybody's having a problem everywhere in the world, okay? Yeah, we got everybody beat. We're the top line, but here's even Korea, France, Italy. Italy kind of was doing okay, but then they went up. Austria, Spain, England, Canada. So it's a problem. It's a massive problem. Here's heat maps. So this is age adjusted. So this is 1990 up here, and this is down to 2020 right here, and this is 2030. As the heat map gets darker, that reflects, this is for BMIs over 30 on this side, so obesity. So you can see here it's getting darker, here it's even darker, but now it's over here in the Midwest, or the, central and western states, and then now everything is red. The prevalence is increasing the darker it gets, and now we are just as saturated as possible with the population who is obese. And then here is, on this side, the right side, that's morbidly obese. Again, here's 2020 right here, the fourth one down. Look, we're into yellow, and then by 2030, we're now starting getting into those reds and oranges. And then this bottom one, so this is kind of the same idea on the top, that's obesity, but the bottom one is diabetes. Look at diabetes from 1994, my button's not working, over to 2015, and you can see how they kind of correlate, obesity and diabetes. Type 2 diabetes and overweight, obese definitely correlates. The ethnicity, so when we look at men versus women, this is total population right here, but when you look at the difference in the prevalence of obesity, here's this is white, black, Asian, and Hispanic. So white, black men, and then here's white and African-American females. African-American females have the highest rates of risk factors, the highest rates of cardiovascular disease, and the highest rates of mortality, unfortunately. And that actually also spills over into birth. Giving birth, African-American females suffer a high rate of mortality just at giving birth. So there's a lot of work that needs to be done. So the shape of things to come, yeah. Even losing 5% of weight, 10 pounds, for example, for a 200-pound person, reaps significant reduction in your cardiovascular risk. So 2.5 millimeters of your blood pressure going down is, on average, the impact it has is significant. 5 millimeters, obviously better than 2.5 millimeters, and no different with weight. If you lose 10% of your body weight, the impact is significant. If you're on medications, you'll see some of those medications starting to melt away. Your numbers getting better as far as your A1C for diabetes, cholesterol numbers, and your blood pressure numbers. One comment here in this pictorial is what represents the gist of this slide. Really, our body makes all the cholesterol we need. We really don't need to. Now, there's disease processes where if you have a disease process where that isn't the case, the rest of the country, the rest of the world, we make enough cholesterol. So anything that we're putting in our mouth that has cholesterol is excess cholesterol for our body. Just fun fact. So 10% decrease of blood cholesterol can reduce your cardiovascular mortality by 20 to 30%. So you kind of get the theme here where like lifestyle is massive in the impact that it has on the #1 killer worldwide. So good fats, salmon, avocado, olive oil, flax seeds can all increase that good HDL, H for higher, that's what we want. High fiber diets, whole grains, decrease fat absorption. So high fiber diets, there's multiple benefits to a high fiber diet. Your fruits and vegetables are those natural types of fibers. A lot of us, as we age, require additional fiber supplementation, but lean meats, so on and so forth. We talked about blood pressure goal of 120 over 120 being our goal, 120 to 130, 130 being pre-hypertension. Like Harry said, losing 10 pounds can make a significant impact on your blood pressure. Again, as you monitor with the weight loss, it's pretty impressive. And then what that's doing on the inside for your cardiovascular disease risk is huge. So I think that's good enough. Okay, so we have a lot of services. We have a lot of free healthy living classes on physical activity, heart health, living healthy with heart failure, healthy living, disease management, obesity, a lot of patient-free classes that are offered, and you could go on the websites. This is just an example of what we had the last quarter in October. Stay active away from home, shop and cook healthy, eat healthy during the holidays, manage stress, heart health, get support. So just to give you an idea. So in summary, it takes a village. Our heart failure program at UCI is massive. And I wish I would have put the picture of all the folks on the little circles with everybody's face, which would take up the whole slide. We have health coaches who help navigate the health system, who help navigate other doctor's appointments, your medications. We have PharmDs who do help and preempt as far as refills to make sure that patients stay on their medications and avoid lapses in the medications, so on and so forth. Social workers, dietitians, we have the whole compendium of folks. Like I said, it takes a village. I mean, like I prefaced the beginning of this talk with, there's so much. I don't know how to put it in a nice little nutshell. So instead I go fast and just try and touch on a lot of things, and hopefully you are able to get something out of it. And this is the heart failure program. I joined UCI in 2006, and in 2008 I started the heart failure program, and we've had every accolade under the sun that you can get. And in fact, for all the medical campuses, for the UC Office of the President in 11 and 17 deemed our program the model for all their medical campuses to follow. So our outcomes are very good. We put our arms around our patients. So, okay, I almost did it. All right. Thank you.
Thank you, Dr. Lombardo. So I'm going to go out into the audience now and let them ask you questions. That was it was wonderful. We really appreciate it. So if you raise your hands, I'll come over and get your question.
Thanks, Adrienne. Most of us are given the advice that we should have well-person checkups. But
Have what?
Well-person checkups. But women have been neglected in the cardiovascular area. Do you suggest that all women get a cardiology workup, even if they have no symptoms?
I think that going to your primary care physician, routinely based on what, your age and disease processes and so on and so forth, and making sure that those primary care visits, that not only is your physician talking to you to make sure things are stable, but you're also bringing up things to your provider or your care team that perhaps something just seems off. And I remember I made that comment about women, waist up. It's not this, or I can't breathe. Just like, I'll give you an example of a patient, I've cared for her now. She's in her late 70s now, and I met her when she was in her late 60s. And she had been going to her primary care provider just saying that, she's an avid walker with her husband, and, there were some hills. Well, she ended up going to eat, I don't know the name of the restaurant. Anaheim Hills, maybe? It's up on a hill? Is it called the Hill? Orange Hill? Something, whatever that restaurant is, okay? She went there, and she was like, I couldn't breathe. And she's like, but, basically her physician was just telling her, well, you need to, you're not in shape. And she's like, it didn't jive for her. And so, I'm not saying that I'm all knowing. I'm not saying that at all. You just got to listen to patients. And that's why I say it's not just the provider asking you questions, but don't write things off just because, I'm getting older. You know what I mean? If something is changing, there needs to be a reason. You need to look for it. And so listening to the patient. So well visits are very important with your primary care physician. Personalities are important. I mean, there are certain patients that gravitate to me, and there's different patients that gravitate to one of my colleagues, right? If they want an earful, they'll get it from me. And I don't mean an earful in a bad way, just a lot of education. Versus others, some patients just like to be told. So find a compatible primary care physician and then, move forward from there. But as far as a routine cardiac workup, which was what the question was, there are age-appropriate tests that are done, but any of your risk factors, any of your disease process, they're not controlled, and something doesn't seem right. Workup should be started, definitely.
Is CVD hereditary?
Yeah, so cardiovascular disease. So it was 2011 when the World Health Organization finally declared that cardiovascular disease is a preventable disease. Genetics plays a role from a cardiovascular disease standpoint. It's estimated now that it's maybe 4%. Something like that. But there's something called epigenetics. So even if you have a genetic predisposition, which it can vary depending on what the disease processes are. How you live your life can have a significant impact on that. You're not preordained. Again, so many people who come in and it's like, my dad, my uncle, my mom's brother, or my mom, they all had heart attacks by the time they were 60, and this person's 61 walking in the door, and it's like, way I look at it, I'm living on borrowed time. And it's like, no, not at all. Then you got another 25 years possibly of borrowed time. If you do things right, keep moving. Keep challenging yourself mentally, emotionally, keep your numbers good, go for those checkups, be honest with your provider, and if your provider's not working for you, change your provider, That answer your question? Yeah?
I wanted to know where your physical office is. I know UCI has a lot of different facilities.
Right now, I am starting a couple of big programs. I do run the heart failure program, and I have several heart failure physicians who work with me, but I'm only seeing patients I've been seeing for a while right now, for another year. Then I will be wide open again, because I will have given all my patients to my colleagues by then, but, and so I will be taking lots of patients at that point. But my colleagues are pretty darn good, so. Oh, where? Oh, I'm so sorry.
Physical address.
Physical location. Oh, everywhere, at all the UCI locations. So if you would like, if you want to talk to me afterwards, you can tell me what you're thinking about and what you're feeling and what your thoughts are, and I can match you up if you like. Okay?
Hi, doctor. I have a question. You mentioned a lot of people as they get older will have atrial fibrillation. And you also put up their beta blockers. And doctors, it seems, are very quick to instantly prescribe beta blockers. Yet, if you read about them, they have very serious side effects. So can you address that issue?
Yeah. So the beta blockers that I put up there was actually for the world of heart failure. So those are one of the 4 pillars that we get that particular patient population on. Beta blockers in and of themselves. So for example, I'll get to AFib in a second. I want my patients on these medications at minimum, right? But like I said, I don't walk in and say, you need to do this. This is a conversation that we have together about what are the potential risks. So for example, beta blockers, if you have a history of depression, can worsen depression. That's a big thing. Erectile dysfunction in men, especially if you already have erectile dysfunction, but it's in the early stages. So these are 2 of the more prominent. If you have asthma, if you have COPD, so on and so forth. So having a conversation and being very frank with the patient about whether or not this is what we're going to do, or this is what's the best. If both of us agree, this is what we're going to watch out for. And always talking about expectations, and then if it doesn't work, it doesn't work. And if it does work, and we get through it, because again, everybody's body, like I always say, nobody's body reads the book. If I had a nickel for every patient who came to see me who had asthma or erectile dysfunction, and I got them on a beta blocker, I wouldn't be rich, but I'd have a lot of nickels. Everybody's body's different. You just got to listen to the patient. You need to talk to them, educate them, and then listen to, tell them what to watch out for, and then listen. And then adjust. And talk about what that adjustment plan is also. Don't just say, oh, just try this, and if you get this, call me. I always take it to each, a couple of branch points out, and then so on and so forth. Now, with regards to atrial fibrillation has got a bad rap in terms of how we treat it. Over the years. Early on in my career, we always went for there's rate and there's rhythm. Rhythm is the abnormal rhythm is atrial fibrillation. Rate is how fast it's going. So it always used to be that we gave these medicines, which were a small handful of medicines that we would give to try and get the rate back to a normal, synchronized, that soldier at the top setting the pace, if you like. All right? So we'd try and get the rhythm. Did I say rate? I made a mistake if I did. We're trying to get the rhythm back to a normal rhythm. But the side effect profile, the medications that we had, 25, 35 years ago, was quite prominent. And there was a study that came out in early 2001, which actually showed in a more aged population that perhaps rate control was better, and that we shouldn't try and get them into a normal rhythm, and just give them, like a beta blocker, which is going to just control the rate. That's not something that's trying to convert them to a normal rhythm, and it's obviously not a procedure that's getting them, trying to get rid of the rhythm. But there's been several large studies over the last couple of years that, perhaps we're not serving our patient population well, because it's keeping them in atrial fibrillation with a rate control goal, like a beta blocker, can lead to an increase in adverse cardiovascular events, all the things, anything that you want to talk about with regards to cardiovascular events. So beta blockers in and of themselves, I'm sorry that you've been prescribed it and you maybe didn't have a frank conversation. I mean, I always say, our role is an educator. I've gone through boatloads of training. I am not all-knowing by any stretch of the imagination, but I got a lot of experience in Gestalt, and I'm going to share with you what my experience is and my medical and scientific And based on that, let's try and find the best, plan that works for you. So that's how it should be happening.
Pardon my English.
Yes.
My doctor, she ordered a test for me, the stress test.
Yes.
I want to know what stage I am in, and also she told me that it may take 1 month to have appointment. Do I have to look in other place so I can diagnose early?
Well, generally,
do the
so
test?
what I tell patients with regards to stress tests, so, every provider is busy, okay? And the first thing that goes in a busy practice, this is everybody, is bedside. And the time it takes to explain and talk and educate. So I always run late. And patients know that, but they know I'll spend the time with them as needed, right? With regards to stress testing, if I had a nickel for every patient who came and said, I had a stress test, my heart's fine. It does not mean that at all. All that means is that you don't have blockages that's significant enough that manifests as a problem during a stress test, okay? It doesn't mean the stress test is terrible. You have to take the right patient, the right disease processes, and the right symptoms. What is the outcome that you're looking for? I mean, I can say I'm having chest pain and I can go have a stress test and it's negative, right? But what if it came back positive? And it's like, oh, it's a false positive because the likelihood that I have heart disease is low, right? But you take somebody who is you take somebody who's high risk and put them on a stress test, and the likelihood it's going to be positive, right? But if it comes back negative, it's like, oh, that's probably a false negative. And then the point is that testing, you have to explain what is the purpose of the testing and what are the expected outcomes and what does that outcome mean. So you go for a stress test, for example. It depends on what your disease processes are, what your risk is, what are the symptoms that you're having, what type of stress test, because it depends which type of stress test, and then what were the findings on that stress test. It's not like a flat, it was negative or it was positive. All right? There is a bunch of data that's collected during that whole time during that stress test. It's looking at all the data and ultimately then looking at the patient and correlating the two, that the likelihood is high, low, or intermediate. And if it's intermediate, you perhaps want to do more testing. The thing I can say about they said a month for your appointment, this is what I always tell patients. That if you're going for some type of testing, if there is something that's bad, they're not going to let you leave. That doesn't mean, as a general rule, I don't know everybody's practice, but as a general rule, if there's something that's bad, somebody's going to talk to you, okay? But that's got to be, that means it's bad. Now there's the intermediate, that's the rest I can't really say. As far as maybe there was a little of this and a little of that, but altogether it didn't mean anything to the people who are doing the test at the time. And you need to talk to your provider because your provider knows why they ordered the test. They know who you are, and it's very important. And so then maybe just call and ask for an early appointment.
Because I didn't have the appointment.
Maybe you talk to her afterwards? Okay.
Thank you, first of all, for spending the evening here with us. Very interesting. Question for you. Early on in the talk, you mentioned that chemotherapy, if you've had chemo, that could be a risk factor going down the road. I'm wondering, first of all, can you elaborate on that a little bit? And then secondly, as you get further and further away from that chapter, does that minimize or mitigate that risk, or is that risk with you until you no longer are worried about risk?
Yeah. I know it's always a little scary to make the comment that chemotherapy, first of all, can lead to heart problems. And hopefully that is definitely a conversation that was had with you at the time that, the options for chemotherapy were presented to you. But I'm going to speak from a cardio-oncology person. My goal never, as a cardio-oncologist, person who used to do cardio-oncology, my goal is never to stop the patient from getting the treatment that is the best treatment for them. but you have to look at the patient. It's like anything. If you have risk factors, it increases the risk for adverse cardiovascular events just from getting the chemotherapy, depending on what the chemotherapy is. But that's a conversation that's had at the time when the options are being laid out to the patient as far as the chemotherapy. So ultimately, you want to look at the patient's risk. You want to look at what are the options as far as treatment, and everything's going fine. So if it's all figured out and everything's going fine, and then say maybe mid-treatment or towards the end, whatever, it doesn't matter, things aren't going as well, all right? There are things also that can be done that can help to mitigate the cardiac problems that are taking place to allow you to complete treatment, okay? So now you get through treatment, all right? You know, and depending on the type of cancer, the type of treatment, so on and so forth, you know, there's a survivorship. So generally 5 years remission, so on and so forth. As, you know, breast cancer, for example, you're in remission and you move into a survivorship mode. Again, depending